Guys.
Introduction, Dan, and thanks for agreeing to chair. And thank you to Penny and Colin as well for the hard work, and particularly sorting out all the technological issues in the first presentation as well. It's really helpful. So I'm going to try and share these slides now. Yep, looks like it's working fine. So yeah, for those of you who haven't met Dan Harman, one of the consultant community geriatricians working for CHCP, and Anna Folwell is next to me. We'll swap seats. I'll go the long way around to keep socially distant halfway through the presentation. Needless to say, there's been lots of provider organisations and partners that have worked closely with us since we started the work trying to improve the care of frail residents in Hull and latterly in East Riding since 2018. And this is a slide simply to represent that. And again, many key individuals, too many to name in a 30-minute presentation, but as I say, these slides will be shared, or happy to share them, and we're very grateful to these individuals as well. So I want to take you just back a couple of years to 2018 and talk about when, as a system, we opened the Jean Bishop Integrated Care Centre in Hull. Anna's going to fast forward us through to 2020, the current year, which has gone pretty quickly, and really how we've had to rapidly redesign frailty services to support people during the COVID crisis. Try and share with you some lessons that we've learned during this time, and try and look beyond COVID, whenever that may be, to a future care model providing proactive and reactive care to frail residents in Hull and East Riding, and talk a little bit about some of the critical success factors that we've identified and some top tips as if anybody's thinking of any service redesign. And as Dan's alluded to, he's kindly agreed to share any questions at the end. I might try and answer some of the questions in the chat box as we go, just through text, just in the interest of time as well. So we'll see. So I think if you live and work in Hull or East Riding, you'll know Jean Bishop is. If you're from further afield and you've dialed into the wrong webinar, Jean is a woman of the city of Hull and an absolute legend, who we've had the real privilege of caring for in her later years. And also she opened her centre where we and Anna are currently based upstairs today at the Jean Bishop Integrated Care Centre, which for those of you that don't know is at the old David Lister School site in East Hull. And it's fitting that a frailty centre is named after Jean for all the work that she's done in raising funds and awareness around older people's care in Hull. I'm pleased to say that Jean is still with us in a care home in Hull, but it's obviously having to socially distance at the moment from the rest of the world because she lives in a care home. So moving on, health inequalities in frailty. So when we started on this journey with Dan and colleagues in the CCG in about 2015, we were looking at a care model for older people that was really around being the frail elderly as a label, with very disjointed episodic care that often resulted in hospital-based admissions. And where we were trying to get to was actually considering an older person as a valued member of society, living with a long-term condition such as frailty, trying to identify and prevent acute illnesses and proactively manage somebody with wraparound services, which is more community-based. And the reason that that's important is we know that the preferred place of care for people living with frailty is often home. And yet people living with moderate and severe frailty, whilst they make up a small proportion of society, actually end up occupying a lot of hospital bed days through no fault of their own, just through the fact that we don't have services set up right to care for people in their preferred place of care. What we tried to do in Hull was use the electronic frailty index to identify a cohort of residents in Hull that were most at risk of severe frailty. And we used something called the electronic frailty index, which we'll explain a bit about later. And we identified about 3,200 residents of Hull, many living in their own homes, but some living within care homes that were at risk of severe frailty. Many of these patients were in their last 12 to 18 months of life. And so we felt it was very important to focus on living well with frailty, but also dying well with frailty. We shouldn't be shy of talking about that as well. Advanced care planning has become very much part of what we do in terms of comprehensive geriatric assessment. So looking at our local system, we needed to understand the agenda, how we could measure success, what would be our key performance indicators, for want of a better word, but also recognising that there are competing interests, perhaps sometimes between provider organisations and perhaps between individuals around what good looks like. Trying to identify the service gaps that exist and the services that exist that could support older people and people living with frailty in our system. You'll notice I've used older people and frailty in different parts of this presentation. When we talk about frailty, we talk about decreased resilience, and age shouldn't be a barrier to somebody accessing a frailty service. So you'll see later that we do care for people who are much younger than would traditionally be cared for by older people's services. The key work streams that we've been involved in previously as community geriatricians have been around rehabilitation in a community bed setting or in a patient's own home, and care homes. We had a small care homes project up and running prior to 2018. But the bit that we felt was missing was really caring for people in their own home in terms of providing comprehensive geriatric assessment. So we were looking to radically transform frailty services rather than just lift and shift traditional outpatient services. How we've made this happen is through, I think, a healthy working relationship with the local CCG and through whole CCG, through the board and through the council of members, GP leaders, through the primary network clinical directors, and through extensive public engagement. We've had to be really clear around governance structures as to who's delivering the care through the Jean Bishop Centre, who's responsible for that care, and onward care after assessment at the Jean Bishop Centre. Leadership is not just about the managerial and operational leadership of new models of care, but also the clinical leadership. And a bit that Anna and I struggled with, and colleagues, in the first year of operation was being really torn between trying to deliver care in too many areas, and both of us moved to be full-time consultant community geriatricians in January. And I think that's been really important in terms of having dedicated leadership time to this aspect of the model, which has been particularly relevant during the first wave of the COVID crisis. We've also had numerous steering groups set up through primary and secondary care networks and other third sector providers and community providers. What we're going to try and do now is try and get one of our patients to articulate the model to you better than I could. And I think I'm now going to give up my screen share to either Penny or Colin, who are going to share this video.
If you stop sharing, Dan, I'll share from my end.
Thank you.
Are you still sharing, Dan? Because we can still see your screen.
Yeah, I should have stopped now.
Okay.
Yep.
Okay. So my screen.
Yes.
This time I've gone straight to YouTube. Let me know if you can hear the sound, and then we're good to go. Can you hear sound?
Perfect.
It's been marvellous. I come round. They've really looked after me. After
yeah, it was surprised when, because in the morning they were pick us up. I wasn't keen on going, but when we got there, they really looked after us, didn't they?
I could tell you straight away. That was great. If I was paying private, I couldn't have been any better. I like the specialist. He said, just call me Dan. That made me feel at ease. Just call me Dan, he says. And I'm a lot happy now. I know I'm taking the right tablets. They've looked after me, took me off the other tablets and half a water tablet, and I'm a lot happier. You know, you're getting the right treatment.
Nothing was a trouble for them to do for you. A therapist, yeah.
Oh, I sort of wanted to know how I got about, and I said, I can't get about. And she says, we'll get you an electric chair. See,
yeah.
It was only a couple of weeks ago. I wasn't waiting long for it, and now I've still got that ordered. I'll be able to get in the back garden because council built me a ramp, big ramp, to go from into our back way, so I could get down with a wheelchair, big ramp, and I've been wanting to get down.
The thing is, they had the ramp built, but I can't push him back up the ramp. No, push him down, all right. But I can't get him back up again, and that's the problem of us not getting him out.
Oh, I'm getting out now.
That's it, isn't it?
I couldn't get. It was in our back kitchen, wasn't it? And I kept looking at it and looking at it. And I've got on it all day, didn't we? And I got round the corner on it, near this corner shop. And I said to them, well, I'm going to carry on to park. And I just carried on to park, didn't we? And had the coffee.
Yeah.
Didn't think I could.
Yes.
Not first time. That said, so I said to them, and now I'm getting a bit used to it. I said, we'll have a wheelchair taxi, maybe to Marx's, where I can get another drive straight on and come off, and I can go and have a coffee in Marx's and go around the store. It's nice that to go around the store. I wonder if it won for the Jean Bishop Centre, I wouldn't be here. I won't be sat here.
Thank you, Colin. I'll go if you exit your screen share. I'll come back in now.
Yes, I've stopped sharing now, Dan. So
thank you.
Take it back.
Thank you. I think we're back in. I mean, I think that what's really lovely about Ray's story is, you know, Ray is one of many patients that we've treated through the Jean Bishop Centre, and the narrative that he gives is very consistent with the narrative that a lot of patients, families and carers give, which I'll talk about in a sec. But Ray was in an absolute pickle before we got involved. I think he was on something like 17 meds. As you can see, he hadn't left the house, he couldn't walk. He was really struggling and he'd given up on life, and he didn't want to come to the centre. He was very mistrusting really of health services. One of our colleagues connected with him when they went on a pre-assessment home visit, and on the strength of that conversation he came, and we were able to change his quality of life. Now, Ray died about 6 months after he came to the centre, but for Val and for Ray's closest friend and best man who came to tell us about his death, they felt that they'd got Ray back for those. And I think someone's put in the chat that you can't put a price on that. And, you know, I think myself and Anna as clinicians, sometimes we get very frustrated when we get bogged down in the things that we can't do. And actually sorting Ray out was one of the simplest things to do. It required people who had been specialist trained in looking after people with frailty, but given the time to care for somebody properly and the right facilities and networking, and it was just easy to happen. And Val, his wife, still comes to the Jean Bishop Centre on a Friday morning for a coffee morning. It's lovely to see her and actually see the difference that the whole team made in their life. So really grateful to Ray and Val for sharing their story. So just to talk a little bit more through that journey. So the way that this works really is that the electronic frailty index is run within primary care by System 1 and EMIS practices, and they identify patients at risk of frailty. The practices can also identify patients who are not flagged on the EFI, but they feel are living with frailty and might be struggling. They contact the patient and their family, make sure they're happy for them to come to the centre and for information sharing, and then that's when we take over. So once we know that that agreement's in place, we'll contact the patients, and then we'll organise a pre-assessment home visit, which might be carried out by a member of our clinical support worker team. Complete questionnaire called a patient concerns inventory that we designed through some local research and a Delphi group involving residents of Hull as well as patients and staff. And it really is a list of prompts around health, emotional, physical, mental health well-being, and it identifies what the individual feels that they are struggling with and need support with, so that when they then arrive at the Jean Bishop Centre for their scheduled appointment, we know which members of the team that they need to see. And the kind of team members that exist at the Jean Bishop Centre are clinicians such as myself and Anna as consultants, GPs with an extended role, advanced nurse practitioners, therapy teams, both physio and occupational therapy, nursing including clinical support, meds management team, so pharmacy and pharmacy tech, social care team. I always miss one group, the Carers Association are here as well. KISS to help provide that carer support that's so vital and so critical to somebody functioning well in their own environment. I've already mentioned that it's not age-based, it's frailty-based, so we do see younger age patients as well. And if you live in a care home and not your own home, we take the model of care to you. If you're truly housebound, our team come out and do a domiciliary visit as well. So when the patients arrive, they have a dedicated transport service, which is absolutely critical for some patients that otherwise wouldn't be able to come to our services. They're here generally for the duration of the morning, seeing those different team members, and then they're given offered a meal here as well through our voluntary sector cafe, which is fantastic. And then they're on the way home. And then we have a team meeting in the afternoon, a multidisciplinary team meeting, where we generate the integrated care record that is shared with the individual and with their GP and with the hospital sector as well. So that record is shared across the system. We also have same-day diagnostics, so we can get plain film radiology done on the day, and phlebotomy, so we can get basic blood tests that would facilitate the correct clinical decisions, particularly around adjustment in medications. As the model's developed, we've also set up chronic disease specialty MDTs. So we've got COPD, dementia, diabetes and Parkinson's teams set up to work through the Jean Bishop Integrated Care Centre. And then we've got these MDTs either weekly or monthly between the specialist services to help with that integration of care. The next two slides are just really example screenshots of our pre-assessment tools that are based within System 1 as we use System 1. And our comprehensive geriatric assessment templates. I'm very happy to share those with people if they just drop us an email. I talked again about living and dying well. The respect form is what is used locally, as we know, to document somebody's advanced care wishes, which has been particularly relevant during COVID, but we now use this electronically, and we offer an advanced care planning discussion to every patient that attends the ICC. The uptake is about 70%. Some people just aren't ready to discuss this yet, but we again offer the ability to come back and discuss it or discuss over the phone with our team if somebody wishes to discuss this at a later date. I talked about using the electronic frailty index to identify and to case find patients for this model. We like the EFI because it's quick, it's easy to use, and it can be used both in System 1 and in EMIS. One of the difficulties is with EFIs, it depends upon the depth of coding, and so it can become unreliable if coding is limited. What we've done with the patients we've seen through the model here at the Jean Bishop and in the care homes is we grade somebody's degree of frailty using the Rockwood Clinical Frailty Score, and we've compared the EFI scores against their CFS score. Now, a CFS score of 5, 6, 7, 8 and 9 indicates frailty from mild to end of life. And you can see here that the majority of the first 2,000 patients that we saw, EFI was fairly reliable at identifying frailty, just not the degree of frailty. And this one slide just demonstrates some of the high-level outcomes for the patients that we've seen. What we can see through this new model of working is that demand for healthcare is being managed. We've seen a greater than 10% reduction in GP appointments, ED attends and emergency admissions for the cohort of patients that we've seen, comparing their 12 months prior to assessment and their 12 months after assessment, and comparing them to a cohort of patients who are frail who have yet to receive this ICC style service. And we can see greater improvements in healthcare usage if we look at emergency attends and admissions for those patients deemed to be frequent flyers. So that's the patients who've had 3 or more ED attends or admissions in the preceding 12 months. We've seen initially an average drug saving of approximately £100 per patient per year when you consider inappropriate polypharmacy in a frail cohort. And then if you look at people living with frailty and other long-term conditions and compare those two groups, so for example, a clinical frailty score of 6 or 7 combined with COPD or with dementia, palliative care or diabetes, you can see even greater impact on a reduction in ED attends, admissions and length of hospital stay. So we really feel that data is driving our process around what we should do next. And when you look at the care homes, we initially targeted care homes that had the highest hospital attends and admissions and also the lowest CQC ratings. And therefore, we felt that was the cohort to really try and go for first, because we couldn't look after every care home resident in this way. So we had to sample somewhere. And you can see for those that received the ICC assessment, a reduction in secondary care usage compared to those not receiving our assessment, where their 12-month usage had actually gone up. But as clinicians, the data is important, but for us, the qualitative aspect of the patient experience is far more important. And that's something that we've focused heavily on in terms of the ICC evaluation. And what patients consistently tell us, and their family and carers, is like Ray, the care that they've received has changed their lives. Frequently used terms are things like they understand their condition better, they feel listened to or valued, they actually feel physically better, and their families and carers feel supported. They know what might happen next, and if their health changes, how their healthcare use might change as well. Staff, we don't have any real issues with recruitment or retention of staff to our model. And I think one of the reasons for that is that staff report feeling trusted to work in a truly integrated fashion. They talk about the reduction in duplication, which can be often so frustrating when you work within health and social care. The value of using an integrated record system shared across the system. And what's been really pleasing is that care home staff have reported feeling part of the team, and they feel that their residents are receiving the same level of care as if they had been delivered in the integrated care centre. We've also tried really hard to share our innovative practice widely, both locally, as we've done now, and as you know, off the national call that we've just returned from. NHS England and NHS Improvement have had eyes on us as well and have visited on several occasions, and that's been really pleasing for the team to share the positive experience of delivering healthcare in this way. I think what we felt just prior to COVID was we were still very much at the beginning of our journey, but we'd started to develop some trust, credibility and momentum around frail older people's care. And this was the plan for sort of phase 2, was to really build on that MDT structure with other single organ specialty teams to really develop a rapid access and urgent care model, because this was very much proactive care. We wanted to move on to how can we respond to the urgent care needs of frail residents in Hull and East Riding, and also could we move on to this, looking after the moderately frail cohort, accepting that that's about 12,000 residents of Hull, not 3,000. But obviously this then happened, which changed our thinking, and I'm going to hand over to Anna now to take over.
Thanks, Dan. So I guess we all remember what happened in March, and these were just some of the headlines. So what we knew was that across Hull and East Riding, we had over 200 care homes, over 6,000 residents within those homes, and the vast majority of them were frail, although obviously we do have some learning disabilities homes. But if you include people living at home, we knew we had over 24,000 residents living with frailty. And what we knew is obviously that we were expecting that these would be people who would have high rates of mortality if they did get COVID, but that it was only limited advanced care planning to date. So we knew that we had a specialist service. We had to cease the proactive care because people were shielding at home, and it didn't feel right to be taking the team into care homes and bringing people here and increasing their exposure. So what we felt was that with our specialist skills, we'd be better off running a reactive service, and that it didn't make sense to be postcode based. We didn't want to be turning people away. So the CCGs agreed that this would be across Hull and East Riding rather than just Hull. So we set up 3 work streams, so a specialist advice and guidance line, a care homes outbreak support team, and then a response to the increased community beds, and we operationalised this 7 days a week. We developed guidance, the operational model that I'll go through, rapid technological solutions to help deliver all of this, and a dashboard to help us evaluate so that we could learn and improve as we went on. So in terms of the guidance, we very much wanted this to be all based on individualised care. We didn't want to be obviously denying frail people access to medical care, but what we knew was that we could offer many of the hospital-based treatments that frail people would be offered within the community, and that would be in keeping with their preferred place of care. We wanted to maximise the benefit for individuals as well as the system, and we were using limited best practice at the time. So we spoke with colleagues in London who were a few weeks ahead of us on the curve. The British Geriatric Society were issuing rapid guidance. We knew that we didn't want to be in the same position as Spain and Italy, particularly from the care homes perspective. So I think we're on our 6th iteration of the clinical guidance that we've issued. It's very much based on the hospital guidance, which we then have just updated for people in the community, and focus very much on where people want to be cared for and where we can deliver that care safely. So we've got severity risk markers to help people, as well as clinical frailty, people who aren't used to assessing that. Very simple. And again, we added some advanced care planning kind of guidance and the rationale for this for people who maybe weren't used to making these kind of decisions within primary and community care. So the advice line was to kind of aid decision making and support everyone living with frailty, regardless of where they were. We initially thought maybe this should just be in relation to COVID calls, but quickly realised that actually, non-COVID calls were going to be equally, if not more important. People are still going to be falling, developing other problems, and it was equally important to be offering specialist support to them. Because it was quite a different way of working and requiring, at times quite difficult decision making, we decided that it really did need to be a kind of senior specialist within the team. So it was either consultants or GPs with an extended role in older people's care who kind of manned the lines. And it was available for everyone working within the community from a health or social care perspective. So carers were able to phone directly, as well as then anyone working within the NHS. And we aligned our operational arrangements with other partners, so particularly palliative care, oxygen teams, community nursing, complex care managers. And that was 7 days a week. And then we had the care homes outbreak support team. So this was to offer direct support to all homes within who had outbreaks, very much trying to offer individualized support. We were able to do video calls and assess need for oxygen, antibiotics, just in case medicines, and make individualized escalation plans with residents themselves if they could consent to that, or families. And we did all of this, in conjunction with primary care, palliative care, community nursing teams. We had a team that were able to go into the homes as well, and particularly at the start, I think homes, really valued having that. Often, I think initially, particularly, they felt, our support had been withdrawn because, the doors had been closed, and particularly when they had outbreaks, were really struggling. We were also able to participate with the local authority on some teleconferences, again, kind of offering a bit of education around COVID management and support. In terms of the community beds, there was an increase in total capacity across Hull and East Riding, and we had hot and cold sites. So this meant that we were able to support people with COVID within the community who didn't want to go to hospital, but maybe needed oxygen. But we were also able to take people who had been in hospital with COVID and needed ongoing rehab, but then also offer ongoing rehab to people who didn't have COVID and step up for them as well. So that flex was really important, so we could meet everybody's needs. Because discharge to assess was implemented rapidly, we had a bit of a change in the kind of usual cohort of people that were within the rehab beds. So a lot of people had more medical acuity, so we had to increase the amount of support than previously. And there was a lot of redeployment of staff, including our teams, into those bedded units. But this really integration across teams. And what we found was that we were, instead of stepping up maybe one person a week, we were stepping up 1 to 2 people from their own homes to these beds as hospital avoidance a day. But none of this would have been possible without all the partners listed there. I hope we've not forgotten anybody. If we have, it's unintentional. And I think everybody came together, to work towards a shared goal and collaborative working. I think one of the main things that we asked of primary care in the start was to support with advanced care planning, particularly focusing on people within care homes. The palliative care teams were really supportive in terms of helping practitioners who maybe weren't as confident, and the DP Macmillan facilitators really helped with that as well. So what did we do? So from the end of March when we started to the July, we supported over 1,300 people through the advice and guidance line. So 2/3 were from care homes. We had another 370 who were from their own home, and then the rest were people within the community beds. And in terms of what we found, as a system, there was a sustained reduction in A&E attendances and admissions. Now, obviously, there were a lot of changes in behaviour of people in March and April. People wanted to avoid hospital and going to A&E because of fear of COVID. So we're not saying that we are responsible for all of this. But I think what's interesting is that this has been sustained across Hull and East Riding, whereas in other areas of Yorkshire, the rates are back up, even through the summer, through July and August, that isn't related to COVID. I think we're obviously continuing to, use more step-ups than we were previously. But in terms of calls that we were getting from paramedics, I think Greg's on the line.
Yes,
I think we've spoken to him
question.
quite a lot. We're on first name terms now with lots of the paramedics, which is really good. But of the 175 that we were called about in April and May, only 4% of people went to hospital. We were able to, operationalise other pathways for people according to where they wanted to be. And I think one of the things that we're most proud of as a team is that for the people who did sadly die, we were able to help them die where they wanted to be, in 94% of the time. Normally we only manage that in about 50% of the time. So this is just a bit more detail of the paramedic calls that we had. So the graph on the right just shows the age range. So the vast majority of calls actually weren't COVID related, but of those that were COVID related, they're predominantly for people in their own home. I think that's mostly due to the fact that care homes were able to contact us directly, or we were contacting them proactively. And of those 35, so we stepped up 10% of them, 10% went to the hospital. So as I said, this wasn't about trying to deny people hospital care, but the others we were able to support through various treatment plans and advanced care planning particularly. Of the non-COVID calls, it's a similar age range distribution and a similar pattern in terms of where the calls were from. And again, we're able to support most people staying where they were or stepping up to a community bed with additional support or advice. Obviously, it was quite a stressful time. This was a completely new service, so it was nice to get some good feedback, particularly from Yaz, because this was a completely new relationship that we'd only just begun to explore how we could work together in developing the reactive model in February and March. And I think particularly pleasing is, the feedback that we have had from care homes as well. I think feeling more supported, particularly from the team that were going out. So in terms of the benefits, as I've said, I think the main thing was supporting people where they wanted to be cared for and reducing unnecessary admissions, supporting the care homes during an outbreak, which carries on today. And the fact that the new pathway was well utilised. I think one of the key things was the development of, one care plan and improving the information flow. So we changed the procedure. We shared the respect forms with the hospital, so we were able to directly upload them onto Lorenzo rather than them being emailed across and sitting there for weeks or months. And we were able to use the lessons, you know, in how we set this up for changing things and developing them and hopefully improving them as we've come out of wave 1 and now finding ourselves right back in it. Obviously, there were some adverse impacts. So the people like Ray, who would have benefited from an anticipatory service, weren't able to come. And we know that unfortunately people did go into crisis because of this. And that did result in a higher demand in A&E and across other community services. And unfortunately, they won't have had the improvement in quality of life and experience that they otherwise might have had. Thankfully, we're back up and running in that department. So we started again in July, and we're hoping to continue as long as possible, as long as we can staff it through winter. We're particularly trying to focus on people with chest problems, because we know people with frailty and COPD have high admissions during winter. Trying to work with Humber, again looking at the memory assessment service and how we can work much better together and reduce that fragmentation and duplication that we see so often. We've changed how we're working in the care homes. So instead of going around home by home that we were doing pre-COVID, because the enhanced healthcare in care homes DES has been introduced, what we're doing is seeing all new residents to care homes to try to ensure that they've got the same comprehensive geriatric assessment, and then being able to hand that over to primary care and community nursing to follow up on the in terms of the weekly check-ins that are happening now, and then they're able to refer back to us for if they need specialist support again. And we're trying to define what kind of complex and reasons to refer back, so that we're making sure that we're still seeing the right patients and offering them the right support. And I think this will evolve as we move forward. We've done quite a detailed work with multi-agencies around what good looks like in terms of that enhanced healthcare and care homes, and are just going through a gap analysis at the moment to see where else we need to focus on. We're offering the post-COVID assessments for frail people. So this is for people who are moderately or severely frail who've had COVID in hospital. The opportunity to come for a CGA at the ICC, and again that's for Hull and East Riding, and that's so that we can assess people holistically, make sure that their mental health as well as their physical health is being looked at. And because we've got the links in with the chest MDT, we're able to, we're not stopping people getting that specialist support, because it's the chest team that are seeing the non-frail in terms of that follow-up in the hospital. We're continuing to work with the community rapid response teams in terms of therapists and intermediate care, as well as urgent care. As we've continued, the line is now 5 days a week rather than 7, but we're still able to offer that rapid response. And the other thing that we're working particularly on is improving our connectivity with NHS 111, and this very much supporting the Talk Before You Walk agenda. So from the 1st of December, we'll be running a pilot initially for Hull residents, where if somebody, we're having to do it age-based because 111 don't code frailty, unfortunately, but we'll see how that goes with the pilot. So if a person phones 111, if they don't require a category 1 or 2 urgent ambulance, then we'll become the clinical assessment team. So we'll be able to validate admission if necessary, and if not, call the person, potentially do a video assessment, and then mobilise an integrated plan and make an onward management plan. We'll be able to bring people in if they're not in immediate crisis for a comprehensive geriatric assessment within the centre, or manage people at home or step them up if necessary. We've been very Hull based, obviously expanding a bit more into East Riding from March, but we're working with the out of hospital teams across the CCGs in Humber region to try to come up with what good looks like in terms of a frailty pathway, in terms of proactive management, reactive management, so that we're all working towards similar principles and outcomes. We're not trying to dilute what we're doing, but help everywhere come up to the same standards. So this is about, our place-based teams operating to the same principles, and these are very much around making sure that every contact counts. We want to be seeing and solving problems rather than just signposting constantly to other services. We want to make sure that this is really driven by outcomes that are important to patients. Obviously, system-wide ones are also very important, but it's patients at the heart of this. Supporting the home first and discharge to assess teams, and making sure that all the information is integrated and shared. I think that's one of the most important things that we can do to try to support everybody in what's going to be a really difficult winter, so that we've got much less duplication. So in terms of what we've learned through this whole process, I think initially there was a lot of skepticism about what we were trying to do. I think the centre got called a white elephant. So we knew that we had to develop some trust and credibility quickly. We were able to test out bits of the model before we opened with interested GPs, thankfully. So we were able to pilot within care homes and get some outcomes, and I think prove that CGA does work in our local area, and that was able to, through that we were able to bring people more on board. I think of vital importance is the shared record. It's really frustrating working in the hospital now when you can't see everything. It's very hard to make decisions when you don't know what's gone before you. It's so much easier when things are properly shared and you can see everything. The pre-assessment concerns and being so patient-focused rather than, trying to answer the problems that we perceive to be the problem, I think has been one of the main things of benefit in terms of patients feeling listened to and valued. And I think we've touched on the workforce. We were really worried about recruitment, but it really hasn't been a problem. We're not trying to steal from other areas, but I think a lot of the shared jobs, across Hull and CHCP, the hospital and CHCP, and then also now with the PCNs, is probably going to be the way forward, and that way we can upskill everybody. So the critical success factors, we couldn't have done this without the CCG, and really want to thank them. They understood the scale and the complexity of the problems, and were critical in breaking down the barriers and boundaries across organisations to get this off the ground. Dan touched on clinical leadership, and I think the engagement with PCNCDs has been vital, so that we can learn what works for people in primary care as well as what seems to be working for us, and we can adapt as we're going forward. And setting up the effective communication structures for that level of feedback has been really important. We're also really grateful for the dedicated analytical support that we had from the CCG and continue to have, so that we could see what's happening and make changes as we've needed to. During COVID, we couldn't have managed without the record sharing that was organised at pace. It would be impossible to make decisions for people, particularly when we're getting paramedic calls, if we couldn't see information from primary care. The introduction of an electronically completed respect form that does still need to be printed off has been really useful, and the acceptance of that from the ambulance service, that a wet signature isn't required, of equal importance. And that meant that whilst we had the runners to help with maybe taking medications around the city, like just in case medicines to care homes or to people's homes, they didn't have to be taking the printed forms always. And we'll be forever grateful for the guidance and support that we got from colleagues and the teams listed there. So I don't know if any questions have started coming through on the chat box while I've been talking.